the average risk for colorectal cancer is defined by an individual who is 45 years of age or older, who does not have a personal history of colon polyps or a family history of colorectal cancer. And to have a high risk for colorectal cancer includes individuals who have a family history of colon cancer or advanced polyps. And advanced polyps is defined by like large polyps or polyps that have more worrisome features to it. Also, an individual who has a higher risk of colorectal cancer is someone who may have a history of ulcerative colitis, which is a chronic inflammatory condition of the colon, or even Crohn's disease. So it's really important to be able to identify your personal history as well as your family history to understand your risk. So the guidelines for average risk person, which again is someone who is 45 years of age or older, is that you start at 45 and you could either have a stool-based test, and that may be done either once a year if you do a regular stool-based test, versus once every 3 years for someone who has a DNA stool-based test. Also, colonoscopy is a very good test, and typically in an average risk individual who has a normal colon on screening colonoscopy, this can be done every 10 years. The high-risk population, so again, that is that group of individuals who have a personal history of colon cancer or a family history of colon cancer. And then certainly the higher risk groups are those individuals who have some genetic syndrome that may be associated with colorectal cancer. And so the recommendation in individuals who have a genetic syndrome would be to start at age 40 or 10 years prior to your first degree relative who has been identified as having that genetic syndrome, and if you have that genetic syndrome. And then to do that more frequently in these patients who are identified to have a genetic syndrome. Now, if you have a family history in someone who doesn't have a genetic syndrome, but you have a first degree relative or several second degree relatives like an aunt, an uncle or grandparent who was diagnosed at a young age, then you may want, the screening frequency is a little bit more frequent, and you would do it every 5 years as opposed to the 10-year recommendation for that average risk individual. Overall, in the United States, we're doing a better job in terms of getting our average risk and increased risk patients screened. However, we still have huge opportunities. Currently, we are not at our 80% goal of screening eligible individuals that we're targeting. So there's huge programmatic opportunities to increase screening, right? And so it really has to be done in a way that helps our patients to, number one, understand that they need to be screened, how they can be screened, and how to really usher them through that process, because it can be complicated. For example, in a patient who does the stool-based test and it's positive, they need to have a follow-up colonoscopy to figure out why that stool-based test is positive. And in a lot of individuals, it's difficult, right? So opportunities to enhance completion of screening include patient navigation programs, particularly in our underserved and underinsured patients, because there are so many barriers to completion of screening. And therefore, programmatic processes such as navigation and education and community outreach can make huge inroads in terms of increasing our screening overall. The other point that I think is really important for us to understand is that in the United States, that there are certain populations that have a higher incidence and death rate from colorectal cancer. And this includes the Black population as well as indigenous peoples. And so it is really important for these groups and other groups to understand their options for screening, as well as how they access those options so they can get screened early they can get screened regularly so they can be here for many years to come for their friends and for their family.